Arousals are the punctuation marks of sleep, sudden disruptions in the EEG that fragment sleep and often tie directly into respiratory or movement events. Scoring them correctly is essential for calculating sleep quality, event associations, and indices like the Arousal Index. Today, we will review the AASM rules for arousals in non-REM and REM sleep. First word for word, then explained in plain English, with both adult and pediatric contrasts. An arousal is scored when there is an abrupt shift of EEG frequency, including alpha, theta, and/or frequencies greater than 16 Hz, but not spindles. It lasts at least 3 seconds, with at least 10 seconds of stable sleep preceding the change. To clarify, look for a sudden EEG change, alpha, theta, or fast activity. It must last greater than or equal to 3 seconds. It cannot be a spindle. You can't call it an arousal unless the patient has been in stable sleep for greater than or equal to 10 seconds. In non-REM, no EMG criteria are required for scoring arousals. Only the EEG change must be present. To clarify, in non-REM, it is all about the EEG, no muscle tone requirement, and spindles do not count. Don't mistake a K-complex for an arousal. Only if a K-complex is followed by fast EEG activity, greater than or equal to 3 seconds, does it qualify as an arousal. In REM, arousals must include an abrupt EEG frequency shift lasting at least 3 seconds, concurrent with an increase in submental EMG lasting at least 1 second. To clarify, it's the same EEG rule as non-REM, but during REM you must also see a chin EMG increase greater than or equal to 1 second. Why is this? Because REM is naturally full of phasic EEG bursts. EMG ensures it's a true arousal. In pediatrics, the chin EMG increase is not always required if the EEG arousal is clear. Don't overscore phasic REM eye movements as arousals. If the chin EMG does not increase, it is not an arousal in adults. An arousal scored within 3 seconds after the termination of an apnea, hypopnea, or RERA should be linked to the event. To clarify, if an arousal pops up within 3 seconds of a respiratory event ending, it belongs to that event. An arousal scored within half a second before or after a limb movement should be linked with that event. To clarify, if the EEG arousal and leg movement are side by side, they count together. This helps calculate the PLM's Arousal Index. Other clinical events. Arousals can accompany parasomnias, seizures, or external disruptions like noise or touch. Pediatric considerations. The rules are mostly the same. For REM, chin EMG increase is not strictly required if the EEG arousal is obvious. High variability in children makes consistency critical. Infants and younger children often have higher arousal frequency. Don't overinterpret normal variability as pathology. Arousals contribute to fragmented sleep, poor sleep efficiency, and daytime sleepiness. The Arousal Index is an important clinical metric, total arousals divided by total sleep time in hours. Associations with OSA, PLMs, and parasomnias are especially important. To recap, an arousal is an abrupt EEG frequency shift greater than or equal to 3 seconds after greater than or equal to 10 seconds of stable sleep. In non-REM, the shift is in the EEG only. In REM, the shift is in the EEG, and you must have the chin EMG increase. Link arousals to respiratory events within 3 seconds and limb movements within a half a second. Pediatric rules mirror adult rules with slightly more flexibility in REM. Arousal scoring requires vigilance, but when applied consistently, it provides a powerful measure of sleep stability and event association. Arousals may last only seconds, but they can define the difference between restorative sleep and fragmented sleep. In our next lesson, we will move into cardiac rules, where we track the heart's story across the night. See you there.